So I am going to go ahead and start the recording so that we will have this recorded as well. And what we will do is once I get this recorded webinar downloaded, we will load it onto our training channel that we have on YouTube. So it's go to YouTube and you search Indiana Youth Service Association, or the training channel pops up, and we'll probably replace the old trauma-informed care with this new trauma-informed care recording. So it will be available to other folks at a later date. Also, if you are on and you would like a certificate of attendance, you can kind of scroll through that chat feature. One of the first things that I popped in there was that you can email Jamisha Harris, and that's jharris, Harris, at ndsb.org. Mention today's webinar, and we can get you a certificate of attendance as well for this particular training. So I'm going to go ahead and get started with the webinar, and just so that you guys all know my objectives for this, I have this planned for an hour and a half. Typically, it's an appropriate amount of time to get through this. If at any time you have questions, feel free to go ahead and chat, type those into the chat feature, or if you just want to ask that, make sure that you unmute yourself to do that. But everyone should be muted while we're actually going through the presentation, and you can do that by hitting *6, and then you unmute also by hitting *6. So the first thing that we're going to do is we are going to look at trauma. We're going to look at the impact that trauma has on development, and then we'll spend a little bit of time looking at trauma from the ARC model, and that is attachment regulation and competency, and how trauma impacts all of these three things. We'll also spend some time looking at trauma and its impact on brain development, which goes a long way toward explaining a lot of the behaviors that we see, and understand how it affects normal adolescent behavior and adolescent brain development, usually exacerbating some things or making things more difficult for kids. And lastly, we'll look at the difference between punishment and trauma-informed consequences. So again, if you have any questions at any time, just go ahead and stop me. Unmute yourself by hitting that star button into the chat feature. I'll try to keep an eye on that chat feature and answer any questions that you guys have. So we're going to start with this definition of trauma, and this definition is actually from the DSM-5. So it is a new definition, the Diagnostic Statistica Manual that's used by the American Psychological Association to do diagnoses. And this was something that was added when they did the revision for the DSM-5, and actually created trauma as its own category. So what I like about this definition, this exposure to death, threatened death, actual or threatened injury, or actual or threatened sexual violence, is that they've added that word threatened, because what that does is it actually really emphasizes that it's not the actual event, but it is the perception of the event that will make the determination of whether it is traumatic to an individual. So it does individualize this definition somewhat, because you have that word about threatened that talks about the perception of the individual. But it allows us to be a little bit more open-minded when we are considering what a person considers to be traumatic, because that is going to be very individualized. Now, trauma can be direct, and so an example of a direct trauma would be someone who is in the military and has experienced some type of, if there's been some military action. By the same token, that would also include law enforcement when they're called out to a potentially violent situation. It includes things like being a victim of abuse, or being a victim of domestic violence as well. So the direct is that it's actually happening to you. You're actually there in the middle of it. Witnessing also can be a way in which you experience trauma, and the most common thing that I think that our kids experience, the youth that we're working with, is if they are growing up in a household of domestic violence and witnessing that violence. And that in itself also can be traumatic. Indirectly is learning about trauma that happened to someone that is close to them. And so it could be learning that someone was in a car accident that was pretty severe and has put them in the hospital, a natural disaster. So I think kind of an example of this is when I was doing this, I did this training a couple of years ago down in the southern part of the state, and there had been a murder-suicide, and it was a father who had gone in. He was estranged from the family. There had been a protective order against him, but he went in, he killed his ex-wife and two kids, and then shot himself. And when I was doing this training, there was a service provider who was actually working with a 5-year-old who was the best friend of the little boy who was killed. And this was extremely traumatic for him. He wasn't there. He didn't see it. But he did learn about it. It did impact him because he lost his friend. But part of the problem was, and this is what the provider brought up, was that that his mother, and this was also traumatic for his mother as well, but she was dealing with this by repeatedly talking about it and talking about it in front of the little boy in detail, and that was just re-traumatizing him. So again, it doesn't have to happen to you directly. It can be a traumatic event, even if it's something that's happened to someone else, and that's a perfect example of that. And then the last bullet here talks about this repeated or extreme indirect exposure, and this was added to the DSM-5 specifically with first responders in mind. So those who go out, the EMTs who go out and respond to car accidents and different types of things over time, law enforcement, and again, those things can be extremely traumatic and have a long-term impact. And even though first responders was kind of the audience that this was originally added for, I will say that for those of us who work with kids and hear those stories about the things that they're going through, this includes us as well. So this definition does include secondary trauma, and that really is what that last bullet is about. In order to meet the definition of trauma, to actually get a diagnosis, you do have these other diagnostic criteria, and we will look at those more in detail later on. Things that are going to determine whether or not an event really is perceived as a trauma, actually it's multiple things. So we'll talk about things that happen maybe pre-event, the actual event factors itself, and then post-event factors, all of which will influence whether or not a person is negatively impacted by a trauma. So when we think about pre-event factors, we are, you see this list here. I'm not going to read it to you, but I think it's important to understand that anytime someone has a traumatic event in their history, they already have kind of this exposure to trauma, particularly if they are young and it's some type of child abuse, then other events are going to have other negative events are going to have more of an impact on them. And so what may be traumatic to, what we wouldn't think it would be traumatic if they have this history of trauma, then it's going to be more negatively impactful. So understanding kind of their background, and then we can understand, that wasn't a really big deal, except for them because they have had this history of trauma. They're kind of primed, if you will, to be negatively impacted by other events. Obviously, if they have ineffective coping skills or any type of anxiety, if they don't have a strong support system, all of these things typically are associated with age. Age is one of those things as well. And it's just because they had the lack of experience to be able to develop effective coping strategies and effective coping ways to deal with the trauma. So our young people are going to be more impacted by negative events than we would as adults, and sometimes more negatively impacted by maybe an older sibling or by anybody else in the family, simply by virtue of their age and their exposure to some of these other predisposing factors. The last thing that I kind of want to talk about here is gender. And typically speaking, females are more negatively impacted by a traumatic event than males are. And this is more related to how females deal with an event as opposed to anything that is a genetic predisposition. And how we are socialized to deal with stuff. So females tend to be socialized at a very, very young age around feeling, around emotion, being able to recognize that in themselves, being able to recognize that in others. As a society in general, we speak to our females, to our young girls, more in emotional terms than we do with our young men. And there also tends to be a pattern of thinking that is more associated with a negative impact that females tend to do more than males do. So typically, if something negative happens, generally speaking, females as a group tend to think about it more. They tend to dwell on it. They tend to kind of, just really get down and get caught up into it. And that continues that negative impact. It's like a negative spiral because you think about it and it stirs up all of the emotion. And unless you have an effective way of removing yourself from that negative thought pattern, it is going to continue to have more of a negative impact. Men, generally speaking, boys, generally speaking, tend to distract themselves from that. And so they find other things to do. They remove themselves from that negative thought pattern, and that means that they're not as negatively impacted then by the event because they tend to distract. Now, I say generally speaking because this is something that is associated with temperament, certainly associated with, I think, some socialization patterns that we have as well. So that being said, there are females who distract and there are males who tend to kind of dwell on things and can kind of get caught up into that. So I talk about this and I make sure that I bring this particular point out because we need to pay attention to what our young people are doing. If it's a female, or if it's even if it's a male, are they is this the young person who is really kind of getting wrapped up into this, that they're thinking about this, that they're really dwelling on it, and they have this inability to get themselves out of that thought pattern. And while, like I said, it tends to follow genders, it doesn't always. I have 4 boys, and my third son is a dweller. He, can just, especially when he was a teenager, really get caught up in things, and it was just a very negative spiral that continued to make things worse. I myself am a distractor, so it was really hard for me to understand, why things impacted him the way that it did, because we thought about it differently. But once I figured out that he was one of these kids who was really kind of getting caught up in it and not being able to pull himself out of those negative thoughts, then we were able to come up with other strategies for, helping. I would help him pull himself out, or how he could pull things out, how we kind of put a stop to that negative thought pattern, if you will. All right. The actual event itself also can have an impact. Obviously, if it is something that you're in the middle of, and that you are continually exposed to, it's going to have more of a negative impact. We have to also think about the meaning of that event to the individual, and this means that we have to talk with them about that. If there's something that that's really bothering them, and maybe it was a fight that they witnessed at school, and for whatever reason, they were more upset about it than any of the other kids who had witnessed that. That's probably an indication that we need to explore what's going on. What was that meaning behind it? Maybe it reminded them of a situation at home that we didn't know that there was domestic violence, and this kind of triggered that. So that meaning is important. It kind of goes back again to the definition and the fact that perception. DSM is recognizing that if it seems to be threatening, that can have just as much of a negative impact as something that actually it is physically threatening to the individual. Obviously, the longer a person has to deal with the event, the more negatively it will impact them. So again, being a victim of abuse, seeing domestic violence within the home, having a parent who is experiencing some mental illness or maybe some substance abuse, all of these things, are things that go on for a long time and kind of wear away a person's resources, and because of that, they would be more susceptible to kind of the negative impact. We've had some folks join us since we started. I just want to make sure that everyone is muted. We are recording this, so just to protect the quality of the recorded webinar, please go ahead and mute, and you do that by hitting *6. All right, thanks. Okay, so the last thing in terms of the impact that a traumatic event is going to have is what's in place after the event has taken place. And so certainly if there is an absence of social support, or even a perceived absence of social support, then that is going to increase the impact that it has on an individual. So if a young person feels like they are all alone, they don't have anyone to talk to, they don't have any resources to pull upon to deal with the situation, that they are by themselves. And if their coping skills are not, part of the definition of trauma and stress is that it exceeds the person's perceived coping skills. Now, we deal with negative stuff all of the time, but as long as we feel like we have the ability to deal with it, that we have the resources and the skills in place to handle it, then it doesn't have a negative impact, and we don't perceive that as being stress, and we don't perceive that as being traumatic. But in the cases where we don't have those coping skills in place, we do feel overwhelmed, and we feel like there are no additional resources, then it's going to increase the negative impact of whatever traumatic event has happened. By the same token, if you feel like there's nothing that you can do about it, that it's happening to you rather than you can change your environment, and make a change, then all of those things are going to have more of a negative impact. And we go back to this again, meaning for the individual. So it just kind of talks about how individualized and specific it is to a person, and how it can be so different for different folks. Because if you can find meaning in a negative event, if there's something that's happened that you have, and a lot of times this is where sometimes spiritual belief comes into play, you feel like, well, this is an opportunity for me to learn. This is an opportunity for me to gain new skills. This is an opportunity for me to figure out how to handle other, problems in life. That kind of solution-focused, future-focused attitude is going to decrease the impact of the event. If, however, you don't know why this is happening to you, you don't feel like there's anything that you can do about it, there's no one else to turn to, then again, you can get caught in that negative spiral, and it has more of a negative impact. All right. So it's important to talk about, we have trauma, but we also need to understand the factors that increase resiliency, because we deal with kids and young people and even ourselves and coworkers who have actually endured quite a lot of really nasty stuff, but seem to be doing okay. That they're on track. They're emotionally on an even keel and well adjusted. And part of that comes again in determining the perception and determining these kind of factors, these characteristics, and almost things that will immunize you against a negative impact. So again, if you guys are just joining us, please go ahead and mute yourselves by hitting *6 or just hitting your mute button on the screen so that we can protect the quality of the sound.
Hello.
All right. So when we think about things that build resiliency, those people who just seem to go through life handling everything really, really well, and kind of bounces off of them. There are different things to kind of consider that make an impact on whether or not this is going to negatively impact someone. So the first thing, and we kind of go back to the things that were absent that make it more negatively impactful. But if we have an internal loci of control, if we feel like this young person feels like they have the ability to make change, that the world doesn't happen to them, that actually they control they control what's going on, they can make choices, they can decide to stay in a situation and deal with the negative stuff, or they feel like they can get themselves out of it. That idea of control, that idea of being kind of in power or being able to make choices about those situations really almost seems to inoculate an individual against the negative stuff that they deal with in their lives. So, for example, if there is, you're dealing with a young person who has a parent who maybe has some mental illnesses or has some substance abuse problems, and obviously, if they're a minor, they can't leave. Or maybe they have a choice and they could go live with grandma instead, but grandma is in a town that would require them to change school districts, and they want to stay with their friends and they want to be able to stay at the same school, and they have that choice. When they have that choice, then they basically feel like they can figure out ways to deal with the negative stuff that's going on in the home. So that idea of being able to choose whether or not they can remove themselves from that situation, and it can be a perceived choice as well. They may not have a choice, but as long as they think that they do, and this is something that they're choosing to do, then it almost empowers them to deal with the situation at hand. Another thing that adds to the sense of resiliency is the belief in self-efficacy. And self-efficacy is really a belief in yourself and a belief in your abilities to deal with a situation. Unfortunately, a lot of the kids that we work with have been told by parents or caregivers that they don't they can't take care of themselves. They aren't capable of doing stuff. But self-efficacy is something that is learned, and so we can help our kids learn self-efficacy. We can build in opportunities for them to master different tasks, different situations, and kind of build that sense and that belief in themselves. Obviously, we can also help our kids build positive coping strategies. And so, many times we will have, not only young people, but also adults who self-medicate. They use drugs, they use alcohol to cope with the things that are going on. So introducing more positive coping skills, communication, relaxation, ways in which if it's possible to actually tackle the problem at hand, but at least managing their own emotion and helping them understand that they can manage their emotions. They can have an impact on how an event makes them feel, or at least what they do with that feeling once that's present. All goes back again to kind of this sense of power and this sense of control. Which leads to the next one, a sense of strength. And this can be physical strength, this can be emotional, or this can be, it doesn't say cognitive, but it also can be cognitive strength. So again, for females, a lot of times they will feel helpless and powerless because they may be smaller. With kids, they're smaller, and if they have an abusive situation, then obviously they're not going to physically overpower someone. But being able to kind of build up the emotional strength. And very often our kids have this. They have endured some things that are just, that are horrific, but they still function. They still go to school. They still interact with people in a positive way. So recognizing that and giving them that strength so that they can identify that and take kind of, again, control and power and empower themselves around that. If they have a reason to deal with the trauma, then again, that is going to be one of those things that goes back to choice. I will put up with this because my goal is whatever it is, to get through school, to be able to get out on my own and do things different. And so I'm just going to deal with this until I can make a different change. But that kind of goal, future orientation is going to be very, very helpful in building resilience and helping a young person through a traumatic event. And again, an optimistic attitude. We have, and this is typically a genetically predispositioned, a tendency to either see things in the bright side or to be more pessimistic. The son that I mentioned that kind of would get caught up in this negative dwelling is genetically a pessimist, and I call him my Eeyore. And he seems to kind of, especially and then things have changed because he's now 23. But when he was a teenager, it was like he walked around perpetually with this. It's like you guys all know Eeyore from Winnie the Pooh, that rain cloud over his head. And that was kind of my kid. He was walking, he was the Eeyore, and he even walked like Eeyore. Kind of his shoulders were slumped, and he just seemed down. And it drove me crazy because I'm not an Eeyore, I'm a Tigger, and so I was bouncing around him, which was not at all helpful. Kind of be happy, don't be sad, whatever, and that was not helpful at all to him. But when I recognized that this is where he was, that he was kind of this pessimistic, through no fault of his own, his genetic predisposition, and he could get caught into this stuff really, really easily, then I had to change how I interacted with him. And I wasn't going to get rid, and that the hardest thing for me was to realize that I wasn't going to get rid of the rain cloud for him, because that rain cloud was going to follow him around, because it was just part of his genetic makeup and his temperament. But what I could do was help him find umbrellas to protect him from that rain cloud. And so we did things like a lot of positive self-talk. He had sticky notes on his wall, so that if he started to get caught up in some of the negative self-talk that he did, then he could just look at those sticky notes that were filled with all of the positive things, because he had lots of stuff going for him that he failed to recognize. And so, he would look at that. So our job with our kids is recognizing that, they've experienced some significant things that are going to be negatively impactful, and we can't change that. We can't change what's happened to them, but what we can do, and if they are walking around with that, rain cloud over them, we can help them find the umbrellas that will protect them from that negative stuff. All right. And it is negative, because trauma affects kids, and it affects everyone, in all of the realms of life. So it affects them physically. It makes them more susceptible to illnesses. It makes them more susceptible to other mental health disorders. It makes them more susceptible to being re-traumatized and re-victimized as well. So you have higher rates of suicide, you have higher rates of self-harm, you have higher rates of substance abuse, you have disturbances and problems with interpersonal skills, and communication skills. You will have disruption in academic progress as well. I also mentioned the physical piece. So they just are more at risk of all of these things that we're trying to protect our kids from. And so it is going to be our job to help minimize their rates of re-victimization, and minimize the risk then of all of those other things that they that potentially could again re-traumatize them. I'm going to shift a little bit and talk about what trauma looks like. So how you can recognize trauma with your young people. And trauma symptoms very closely resemble post-traumatic stress disorder. Now, a young person can actually be diagnosed and have a post-traumatic stress disorder as a result of a trauma. But those symptoms are more extreme, and there are other symptoms. So these are PTSD-like symptoms, but still trauma symptoms. And so, again, I'm going to talk about these more in detail, but they typically will feel like it is reoccurring to them, that they are re-experiencing that, and it's different than a memory. They will avoid the stimuli. They will avoid all of the things that were surrounded the trauma event, if they can, or remind them of that traumatic event. A lot of times you will see, if not acting out, you will see some numbing, so that they are just have a flat affect, because if they do feel things, it's very negative. So they just kind of will numb themselves to that, and you don't get a full emotional response. And then they also can have increased arousal. A lot of times in programming, we see this because it's fidgeting, they can't pay attention. But let's talk about these more in detail. So when we talk about actual reoccurrence and re-experiencing of that traumatic event, when we talk about, it's very similar to if you have someone who is OCD, who's obsessive compulsive. These thoughts are not, they're not controllable. And the person will tell you, they just pop into my head. I can't get rid of it. I can't think about something else, because it's just there and it seems to be nothing that I can do about it. So this can happen, in day-to-day life. Something that they see actually reminds them of this, and it then kind of triggers this re-experiencing of the trauma. And what that tends to look like in young people is that they're not paying attention, because something has triggered it. And in their head, they go back to that event. And they really are not conscious of what's going on around them at the time when they are actually re-experiencing this. When I was a counselor at Youth Service Bureau in Bloomington, Indiana, I worked with a young woman who was a victim of sexual abuse. Her dad had been sexually abusing her since she was 9 years old. She was 16 when she came to us. And she stayed at the shelter, and we had a great relationship. Had really good therapeutic rapport, and so she was very comfortable talking to me about her experiences and being able to kind of work through some of those traumatic events and the abuse that happened. And she was telling me about one of those things, very difficult to hear. But I knew that this was helpful to her. But she's telling me about an abusive experience, and I said to her, just kind of, she triggered some of my maternal instinct as well. And I said to her, "Oh, hun, I'm so sorry." And when I said "hun," she kind of disappeared from me. She was there in the room with me, but I could tell that she was no longer paying attention to what I said. And she started to shake and she started to cry. And so I was like, can you tell me what's going on? What's happening? And then she did. She came back, and she told me that when I used the word "hun," that was a trigger because her father had used terms of endearment while he was actually molesting her. And so something that was completely innocent and certainly unknown triggered this very traumatic re-experiencing of that trauma for her. More so that, she was telling me about it previously and dealing with it very well, but that use of that word actually triggered this re-experiencing, which was completely different and far beyond her ability to cope. So we talked through those things. Obviously, made a note that that's not to use terms of endearment with her. So kind of when you're working with your young people, if you see something where they just kind of disappear, they're not paying attention, they really start to get upset about something, kind of piece together. And I would say definitely make notes and pass those along to the other folks that you're working with so that you can start to identify a pattern and identify some of those cues so that we can minimize their exposure to those while they're with us in that environment. There's also a lot of physical reactivity. So as I mentioned, she started to shake. She started to cry. After that experience was over, she had a headache and she needed to go lay down. So all of these are going to be kind of the things that you can look for that are going to happen. The other thing that's on here that I haven't yet talked about is bedtime, and how difficult that can be for kids who have experienced trauma, because if they're not dealing with this consciously, then they're very often having nightmares. And so these distressing dreams are very difficult for them to deal with. And very often they will avoid, they'll try not to go to bed because of those dreams. They will avoid that, which is another, this avoidance numbing is another thing to kind of look for in kind of identifying a traumatic event. So they're going to avoid all of those things that will make them feel negative. And a lot of times we're dealing with kids who've experienced trauma that hasn't been identified. So again, we're going to look for those cues that trigger something within them that can kind of help us put the pieces together. So if they're avoiding different places, if they're avoiding different people, if they get upset because someone's going to come visit, or, we had a staff person when I was at a YSB that everyone absolutely loved, but for this one kid, he reminded him of his physically abusive father. And so he dreaded when the staff person came to work, and we couldn't figure out why it was, because all the other kids loved him, and it just took a little bit of digging to figure out that he reminded him of his dad, and his dad was physically abusing him. So we kind of uncovered some of that by paying attention to those things that really kind of don't make sense. It is very common for them not to be able to recall a traumatic event in detail, to kind of, so the story can change as pieces come together. It's not the kid being trying to be manipulative or trying to be deceitful. It just is, if it's particularly traumatic, a protective mechanism to help them avoid being overwhelmed by the negative stuff. Looking for things that changes in behavior, a diminished interest, detaching themselves from others, again, that flat affect, all of these things, also, so if we just look at the bottom, the diminished interest, the detachment, the flat affect also look like depression. But it just means that we need to dig a little bit deeper and figure out what's going on. The increased arousal also there are also these symptoms that mimic. So if we just looked at difficulty falling asleep, irritability, or acting out, difficulty concentrating, a lot of times this can be misdiagnosed as ADHD, attention deficit hyperactive disorder. But these are symptoms of trauma. We've already talked about why it's difficult for them to fall asleep. If they're having nightmares, then it will be difficult. They have that heightened sense of physical reactivity, so that's also going to make it difficult for them to relax and to be able to fall asleep. Obviously, it makes sense if they have experienced trauma that doesn't make sense to them, that they're going to be angry, that they're going to be irritable, because it taxes their ability to deal with a situation, to any situation. Difficulty concentrating makes sense as well. The two things that are on here that are going to be specific to trauma and may be able to help you differentiate between trauma and ADHD is typically kids who have experienced trauma are going to be hypervigilant. So they're constantly looking around. They are positioning themselves by the exit. They are assessing their environment for a sense of threat, because that's what they've had to do. So kids who have, if that trauma is past abuse, then they are always going to be assessing their environment in terms of their safety, and placing themselves by the door and watching other people so that they can then protect themselves. Another symptom that is going to be typically specific to trauma is that exaggerated startle reflex. So a door slams, and the kid jumps, and you get the arms that are thrown out, and that extreme kind of startled, where no one else is really kind of paying attention. Now, that in and of itself doesn't mean the kid has experienced trauma, but it can be an indication if it's combined with some of these other things. Again, there is this, with the changes in the DSM, a new understanding of trauma, and especially trauma that is reoccurring, that happens to kids over an extended period of time. When they have homes that, they come from homes that are abusive, or there's a lot of domestic violence and this kind of disruption, an understanding that all of this stuff then negatively impacts their ability to interact with other people, their ability to form attachments, to be trustful. And so, one of the new definitions is this developmental trauma disorder, also called complex trauma, which just means that we have to understand the young person and build additional time into our interactions with them to build trust, to understand why they're mistrustful. And a lot of this, again, because we'll kind of go back to this, the ARC model, and how trauma is going to impact attachment, how trauma is going to impact their ability to regulate their bodies and themselves and their emotions, and their ability to build competencies. And so we'll look at these, again, individually. If a young person has experienced this kind of complex trauma, this trauma that comes from a history of being abused or a history of dealing with these negative impacts, then it is going to present a challenge to their ability to bond with other people and to attach with other people. If the trauma has been perpetrated upon, so if it's abuse and it's abuse by a caregiver, particularly if it's a parental caregiver, then kids are going to be automatically suspicious and distrustful of other individuals. Kids tend to self-blame. And part of that is based upon what our society tells kids. Even as young as 3 or 4, kids get the message that mom and dad are supposed to protect you. They are supposed to be the ones who love you more than anybody else. They're supposed to be the ones who protect you from all of the bad stuff that happens. And when it is mom and dad who is doing the bad stuff, and kids have this understanding from the cartoons that they watch and the stories that they read, and everything that they see in society that says that, that's not how it's supposed to be. Everyone else gets protected. Everyone else is loved. Kids tend to then turn that into self-blame because they don't understand. They don't have the cognitive capacity, nor does this match this view of the world that they've been given. And so they then think that something has happened to them. So not only are they mistrustful of other people, but they're also mistrustful that they are deserving of care, that they are deserving of love because of this history that they've had of being abused by those folks who are supposed to be taking care of them. So they will either push people away, and they do that by acting out. They do that by being aggressive. They do that by isolating themselves, and they just kind of build that wall. And they may interact, and they may be polite and get along well, but they don't have that closeness because they don't trust anyone, because that's always caused them pain in the past. So they will either kind of disengage and push people away by those different types of behaviors, or they will have no boundaries whatsoever, and put themselves and make themselves open and more vulnerable to re-victimization, because they do want, as human beings, we want to attach, we want to have that sense of belonging. And so they will take it however they can get it. And will often form inappropriate attachments, or try and be sexually inappropriate if they've been sexually abused, because that's the only way that they have had that type of attachment or gotten attention. So you see both sides of those. A lot of times kids will come home and they have a new kid in a class, and this kid is all of a sudden their best friend, and they want to give them things. They give away their stuff. And they overly attach. So all of this is a result of this inability to understand what a positive relationship looks like, because they've not been given that opportunity if they come from a home with this abuse and this trauma in the past. So they'll either push you away, or they open themselves up to re-victimization, because they're so desperate for any type of that sense of belonging and positive attention. Trauma also presents this challenge to self-regulation, because they are overwhelmed. They are dealing with oftentimes trauma that has threatened their sense of well-being and safety. They feel and threatened their life, or caused physical harm and physical injury. And so we have a very strong sense of self-preservation, typically speaking, and we will devote our attention to all of the things that we need to do to make sure that we're safe and to make sure that we're protected. And so if all of that energy is being devoted to my safety, whether or not I'm going to be beat when I get home, what mood mom and dad is in, whether or not they've taken their medicine or they've been drinking, that it makes sense that they are not going to have the time and the opportunity to devote to being able to self-regulate their own behaviors. So, again, they become hypersensitive and hypervigilant because they are responsible for their own safety, because the person who's supposed to be doing this is actually threatening that. So they become responsible. They then become hypervigilant and and overzealous, if you will, around making sure that their environment is safe for them. Very often, this will manifest in physical symptoms. So kids will you get a lot of complaints about headaches, a lot of complaints about stomach aches and pains that don't have a physical ailment explanation. It is physical. I don't want to say that it's not physical. I mean, if we think about, a time in which we've lost, someone in our life, that pain is a physical pain, but it's due to an emotional cause. So you will get a lot of trouble regulating. Sometimes you'll see bedwetting, incontinence, and those types of things because their system's just as simply overtaxed. And if they're paying attention to that stuff, then obviously a challenge to paying attention to schoolwork is going to be expected because they simply are overtaxed. At the same token, if they are paying attention to this trauma and trying to deal with the trauma, then they are going to have less resources available to deal with learning the basics, things in life that they're like I said, the academic lack of academic progress, the inability to appropriately communicate, or the interpersonal skills. All of these things are going to be disrupted because they are devoting all of their energy to dealing with the trauma. If it does come from, the trauma is a history of abuse, and again, kind of the primary caregiver, mom and dad, is the abuser, then it will result in this feeling of low self-worth. They do a lot of self-blame. And so we have to recognize that and then help them kind of build those things back up, and help them find their talents, find their skills, find their strengths. Many times they're not going to be able to recognize that. And then demonstrate the opportunities for them to be successful, provide them with those opportunities so that they can kind of build that sense of strength, build that sense of self, and sense of worth around that. So let's talk a little bit, again, shift about what's going on in the brain that explains some of this stuff. Trauma has a very direct impact on brain development. One of the things that is immediately impacted is what's called the moderated stress response. And so in a typical newborn, babies are born into the world without the ability to soothe themselves. And so it is a primary caregiver's response that helps them determine what that stress response is going to look like. And all of this is kind of based upon the pathways that are formed in the brain as a result of trauma, and as a result of stress, and as a result of that primary caregiver's initial response. So baby gets upset, and in a nurturing, good environment, the caregiver will pick the baby up, typically figure out what needs to be met. If they're hungry, we feed them. If they're tired, we rock them to sleep. If they're wet, we change them. And when we do this, We typically are touching them, so there's that physical contact, and we are soothing them. We talk in the tone. It's okay. So we do all of this, and when we do this, what happens in the brain is that the neural pathways for the information coming in and triggering the stress response within the brain, those are all activated. But then when we actually respond appropriately, we create a pathway that allows that stress to be reduced. And so over a repeated period of time, and it typically takes about 4 months. And for those of you who've had kids, you can think back and remember this. You're responding immediately. You're responding immediately because if you don't respond, they're just going to get more and more upset. But after you've done this consistently, and you've appropriately met their needs for an extended period of time, then at about 4 months, babies start to be able to self-soothe. Right? So they may start to get fussy, but then they find their pacifier, or they find their thumb, or a blanket, and they're able to start to calm themselves down. And that is in part due to that it's in large part due to that neural pathway that has now been established. And they then can naturally kind of do that. What happens with babies that do not have the appropriate response from a caregiver is that they kind of get stuck. So they get upset, and it triggers activity in the limbic system, which is where our emotions and kind of the threat system is being processed, and they get stuck there. And that emotional system and the limbic system becomes kind of overactive, and they don't know how to calm themselves down. And they maintain that heightened sense of stress, that heightened sense of reactivity. And that's not to say that this can't change, even if we don't see them until they're 11, 12, 15, whatever. It just means it's going to take a little bit longer to help them establish that neural pathway to be able to calm themselves down. So when they're stuck in that system, that when they're stuck not being able to self-soothe, then you get a kid who is going to be triggered more easily. You get a person who's going to stay in that negative state quite a bit longer. And that is because the sympathetic nervous system has been kicked into gear. They're irritable. They have a higher rate of heart rate, higher blood pressure. And the body has kind of dumped cortisol and adrenaline into the system to deal with the threat, which is good if it's only for a short period of time. But what happens with these kids who get stuck is they have higher levels of cortisol, higher levels of adrenaline. And in both of these cases, particularly with cortisol, it tends to have a negative impact on brain structures. And we'll talk about that a little bit more. But you get this kid who just gets stuck, and who gets stuck and can't find their way down. That's important to understand, because that when you have the cortisol that's dumped into the system for a long period of time, and they're constantly dealing with stressful situations, it actually changes the way that some of these brain structures develop. And so the amygdala, which is a teeny little structure in the brain, in the center of the brain, the amygdala is responsible for processing the information that comes in and assessing emotional content to it, particularly if it has to do with something that is fearful or something that is threatening to the individual. So the amygdala kind of houses all of our fearful memories. All of our other memories are housed in the hippocampus, another structure in the midbrain. But all of our memories for things that were fearful, things that were threatening to us, are housed in the amygdala. And from an evolutionary standpoint, it makes sense, because if it's something that threatens our existence, we need to hold that memory in the very first brain structure that's going to assess whether or not we need to pay attention. And the amygdala says, oh, this is fearful, this is threatening, therefore we need to engage our sympathetic nervous system and get the heck out of here or be ready to fight. So it engages that sympathetic fight or flight or freeze response system so that we can deal with the threat at hand. When you have a young person who has a traumatic background and has experienced chronic or long-term trauma, and usually because of abuse, the amygdala is going to be bigger than kids who do not have that traumatic background. So you actually have the brain structure that is ready to deal with threat and fear being bigger and taking up more room, and because it's had to, because they have to pay more attention to this kind of stuff. The reverse is with the hippocampus, the other brain structure that holds memory, also again in the midbrain. So these are the memories that we need to know, for academic success. This just kind of explicit memories. All of our facts and knowledge and those types of things. All of those are in the hippocampus. And one of the things that happens is that when you have high levels of cortisol over long periods of time, it tends to eat away at the dendritic structure, the parts of the neuron in the brain that make and form connections with other neurons, and those are called dendrites. And so cortisol eats away at dendrites, and you actually have a smaller hippocampus. You have a hippocampus that has, first of all, it's smaller, and then it just has fewer of those dendrites that reach out and receive information from other neurons. So you have less of an opportunity then to pass along that neural communication. Same things happens with the corpus callosum. So the corpus callosum is fibers that nerve fibers that cross between the two hemispheres in our brain. So we have a left hemisphere, a right hemisphere. They communicate all of the time. You can be dominant one way or the other, but they tend to communicate all of the time, and they communicate through this dense sense of nerve fibers through the corpus callosum. And so for kids who have chronic stress and trauma, they have a smaller corpus callosum. They have fewer ways in which those hemispheres can actually communicate to one another. And that's important and can be very detrimental because some of our skills are housed in different parts of the brain. So verbal communication, math communication, the ability to read other emotion and interpret your own emotion, all of those things are housed in either the left hemisphere or the right hemisphere. And the more that we have, the more opportunity we have to pull from both sides of those hemispheres when we have to face a threat or face a situation that requires our energy and our thought and problem solving, the better off that we are. But these kids do not have they don't have that ability as much because that corpus callosum and that's those nerves that connect those two and allow that communication to happen is smaller. We also have a smaller prefrontal cortex for kids who have experienced this kind of trauma. And the prefrontal cortex is housed right, as it sounds, in the front part of the brain. And this is the part that's responsible for all of our our logical problem-solving abilities. So impulse control, higher emotional control is housed in the prefrontal cortex. Moral judgments, deciding right from wrong, priority setting, goal setting, decision making, all of this stuff is housed in the prefrontal cortex. And the prefrontal cortex is very dependent upon the environment and experience to help it develop. And so kids who are stuck in the limbic system, who are stuck with that amygdala, constantly assessing threat, have less of that opportunity to engage prefrontal cortex and less opportunity for those experiences that are going to boost that development, because they're making immediate decisions that to them are life and death decisions. And those decisions don't come from the prefrontal cortex. Those decisions come from that midbrain section, because this is about whether or not I'm going to live through the day. And that immediate response comes from the midbrain rather than the prefrontal cortex. So again, this area that is responsible for all of our higher emotional and logic, kind of rational thought, is going to be smaller in kids who have come from a traumatic background. I already talked a little bit about changes in neural pathways, and I talked about kind of setting that stress response. But you do have, for kids who have a traumatic background, this hyperactive amygdala. It's going to go off at the drop of a hat. And it needs to, because it's had to in the past to protect that individual, to make sure that they survive, that they get out of the situation. And so not only is the amygdala bigger, but it's also hypersensitive. And so you'll get an immediate emotional response, because that is what has helped them survive to that point. You also get that hyperactive sympathetic nervous system. So again, the fight, or freeze response is going to be immediate and will be triggered for kids with a lower threshold than it would for kids who do not have that traumatic background. And so you'll see kids overreact or react, out of context, when for them it really might not be out of context because of the history that they've had. And this is especially having a hyperactive sympathetic nervous system is extremely debilitating if it goes on for a long period of time, because it uses up all of the body resources and makes kids, it wears down the immune system and makes them more susceptible, not only to those emotional triggers, but also any type of physical ailments. So they're sicker. They get colds quicker. They get the flu quicker. It takes them longer to get over that. So you just see kids who are not able to deal with any type of stress, whether it's physical or emotional or cognitive, because of this taxed ability. And then again, an underactive prefrontal cortex. So it's smaller, but they just, the connection between the midbrain and the prefrontal cortex and being able to kind of stop and rationally think about something is based upon experience. And until they have those opportunities to strengthen that connection from the midbrain to the prefrontal cortex, they're simply not going to engage that prefrontal cortex as often as kids who don't have that history of trauma and who have had those opportunities to learn how to engage prefrontal and to stop and to think and to plan. But all of that, again, is based upon experience. And a lot of times our kids simply haven't had those opportunities that would strengthen that connection. All right, so the last change in terms of kind of brain development is changes in neurotransmitters. And neurotransmitters are kind of the brain chemical that elicit certain responses. And there are a couple of different ones that are impacted by trauma and chronic trauma. The first one being norepinephrine. And norepinephrine is it's a neurotransmitter that is really important in terms of attention. And what we find with kids who've experienced this long-term trauma or chronic trauma is that they have lower levels of norepinephrine than kids who haven't had that trauma experience. And it explains and low levels of norepinephrine then explain their inability to be able to kind of focus in on something and this diffused kind of attention. So low levels of norepinephrine, and it gets in the way of their ability to be able to pay attention for a long period of time. But it also kind of, like I said, diffuses attention and explains that hypervigilance that's constantly going on. Another neurotransmitter that's affected by trauma is serotonin. And serotonin is our calming neurotransmitter. It is the neurotransmitter that kind of puts the damper on hyperactivity in the limbic system. Now, remember, we have a hyperactive amygdala anyway, because it's been primed to respond. It's had to, because they've been constantly presented with all of these threatening situations. So it's bigger, it's hyperactive, and the neurotransmitter that's supposed to calm this brain structure down is not present at the level that's needed to be able to do that. So low serotonin is also responsible for things like higher anxiety and depression. And so it makes sense then that kids who have experienced chronic trauma have chronic lower levels of serotonin, and that again explains that kind of hyperactive amygdala and that hyperactive response and sympathetic nervous system. I will say that serotonin is one of those. So serotonin is we use our neurotransmitters throughout the day. And the more stressful the day that we have, the more we use serotonin. And so serotonin, if we have a really, really good night's sleep, we reset all of our neurotransmitter levels, and we have a great night's sleep, and our serotonin levels are set where they're supposed to be. And we just use up those levels as we go throughout our day. And it explains why people are more irritable at night, because you see a decrease in serotonin as the day goes on. And, the lower the serotonin levels, the more anxiety we might feel, the more irritable we will be. And so this is just exacerbated by kids who already start out with low levels of serotonin. So if you guys have programming in the afternoon, and I'm sure a lot of you do, you are going to have kids who come to you because they've already taxed all of their ability to kind of deal with stressful situations. So you're more likely to see them act out. You're more likely to see them get upset or withdraw because they simply they've used up their ability to kind of calm themselves, and that serotonin level has decreased as they made their way through school. So just kind of know that. All right. So let's take this into context with just what's normally going on in adolescence. And there is a specific pattern for brain development. It typically happens from the back to it goes from back to the mid to the front. And so by the time kids get, to pre-adolescence and adolescence, you have the limbic system, the midbrain, fully developed and really kind of primed to go off. So for an adolescent that doesn't have a history of trauma, just for a so-called typical normal adolescent, they already are going to have a limbic system and an amygdala that is primed to respond. They do not have a fully developed prefrontal cortex because, again, this is based upon experience. And the more opportunities we give our kids to engage prefrontal cortex by helping them problem solve and to think about things like right or wrong, or predicting consequences, or setting goals and priorities, all of this stuff takes practice. And the prefrontal cortex is not going to be fully developed until about 25 anyway, so the mid-20s, which explains a lot of the reason that we see variability in kids' ability to kind of engage in thoughtful, logical, rational decisions, because it's, first of all, it's not fully developed, and it's completely dependent upon experience and opportunity to learn those things. So a typical adolescent is going to respond out of their limbic system, out of their emotions anyway. We're going to get typically an emotional response that's immediate without the ability to kind of engage that prefrontal cortex. A lot of times we ask our kids, right, what were you thinking? Well, they weren't. Maybe they weren't. Maybe they didn't have that opportunity to engage that prefrontal cortex. So adolescents already have this tendency to be over emotional because of that fully developed limbic system without the fully developed prefrontal cortex that puts the brakes on those emotions. Remember, higher emotional control is not in the limbic system, it's in the prefrontal cortex. But we have to find ways to help them engage that thought process. So a lot of times by helping them stop and count to 10, what that does is it basically puts the brakes on the limbic system and on that amygdala, and it allows them to engage the prefrontal cortex. So sometimes just doing silly, something that's just off the wall, that's unexpected, if they're getting upset, and you have to catch them before you totally lose it. Just making a humorous trying to find humor in it, or doing something that's unexpected, or if they're yelling, you just get really quiet, and then they kind of have to get quiet to hear you talk, and you minimize your body movement so that you become really still. They might mimic that, and that allows them to stop and engage prefrontal cortex. All right. So I do want to spend the last few minutes talking about the difference between trauma-informed consequences and punishment. And trauma-informed consequences really come out of this idea that it is about helping kids learn how to do something different. So we have to do it in a way that gets their attention, so they, with respect. Certainly you have to take their safety into consideration and be safe. But it is for the purpose of helping kids be more successful the next time they run into a situation that might get them in trouble. So it is very youth focused, it's very problem focused, and it's very future focused. And done in a way that is going to help them be more successful later on. Because of that, you have to understand where this young person is coming from. What has been their opportunity for learning to deal with the different situations? Have they ever seen a problem dealt with in any other way than violence? And if not, then we have to take that into consideration and teach them and give them those opportunities to learn different ways of doing things. So punishment, the biggest difference is that punishment is about what's easy for us. Punishment is about the adult. Punishment is about being in control and making our life and our job easier. And that is not going to be beneficial to the young person. It is actually detrimental to the relationship. And kids are typically going to, if it's because it's what makes your job easier, and they recognize this, and it's not in their best interest, or it's not to help them out, then they're not going to pay any attention to anything that you say anyway. Now, so our ability to have an impact on kids is significantly influenced by the relationship that we have with them, and the fact that they trust us, or they may not like what we say, but if they know that we're doing this because we have their best interest in mind, then they are going to be more likely to kind of listen to what we say. So consequences are designed to teach. Consequences are connected to the behavior. And it helps them learn what to do differently the next time. So I'll give you an example. When my second son started high school, and this was a kid who was in academic honors classes, really bright, and started high school, and was doing honors classes and that kind of stuff, and had a girlfriend, and he probably had got his girlfriend a few weeks into his freshman year, and so he brings me home his first report card, and his first report card has C's and D's on it. And this is not this kid's ability. So he's not performing to his ability. And I asked him, "What's going on here?" And he told me, "Well, I've been talking to my girlfriend on the phone at night, and I'm not getting my homework turned in." All right. Well, the kid gave me his consequence right there. So we knew what the problem was. The problem was he was spending too much time on the phone with his girlfriend and not enough time on his homework. And so he had to get off the phone every night at 8:30 so that he could do his homework. Now, you would have thought I'd killed the kid. I thought I was being extremely reasonable. I didn't take his phone away from him. He just had to get off at 8:30 so that he had plenty of time the rest of the evening to do his homework. And when his grades came up, then that would go away. And lo and behold, his grades came up. He brought me home a mid-report card in which they had come up and said, "Now can we change this?" And I'm like, "No, let's make sure that this actually gets to the actual report card." But he knew what he needed to do. He learned what he had to do to keep those phone privileges, to keep his grades up. And again, bright kid, he knew what he was doing wrong. But if you can tie it to that and help them see how, and we introduced, not only did he lose his phone, but he also then had time to do his homework. So it was what else he needed to do in order to be successful. And that really is kind of what these consequences are about. So it's important if we can catch them being good. And I know that that's a saying that we use a lot, but kids, especially adolescents, are reward sensitive because that limbic system, because the midbrain is fully developed. That is also where our reward system is located, is in the midbrain. So it also is going to be very easily triggered. So if we can catch them being good, recognize them for those successes that they make, and the good decisions that they make, and we praise them and we reward them, for that, then that's going to reinforce that reward system in the brain. They're going to remember that. It's going to be more meaningful to them. Rewards are much more meaningful to kids than punishments are. And so it reinforces that learning at a significantly higher level if we can catch them being good, and it reinforces the learning that we want to occur. It is very, very normal for adolescents to limit test and to challenge. This is directly a result of the cognitive development that's going on, their ability to understand now possibilities and hypothetical situations. This is probably more common in middle school, so early adolescence, as they begin to grasp things like abstract concepts such as equality and justice and individual rights and those types of things. And they're just testing out their world. They're trying to figure out what the boundaries are. We all want to work within our boundaries, and we want to know what those are. And so if we can provide kids with safe places to do that, so that they know what those are, and then how to structure their behavior based upon that. It's like you might have to help them understand that, in some classes they are able to ask a question, they are able to challenge a teacher. And in other classes, they're simply not, because the teacher's not open to doing that, but that helps them then be able to kind of modify their world. Adolescents are typically emotionally immature, again, because they're stuck in that limbic system and not engaging the prefrontal cortex that has that higher emotional control. So they are going to respond emotionally first. They are going to stay longer in negative emotions than adults do. It takes them longer to get over the negative stuff. So just know that. They feel things more intensely, and they have this inability to translate what they learn in one situation to another situation. So what they learn in your program, they may not be able to transfer that skill to school or to home until we help reinforce that learning in both of those places. And so that's why that repetition and consistency is extremely important. It takes the average person 6 times to hear something before they remember it. 6 times, an average person. Adolescents, you're probably going to have to say it a few more times. There's a lot of parallel between adolescents and toddlers in respect to what they need from us as adults because of what's going on in their brain based upon that brain development. So the more that we can be consistent and repeat all of the things that we want them to learn, the better they're going to be able to hear it, to grasp it. So we write it down for them. They write it down. They hear it. They say it. They act it out. The more ways that we can actually reinforce those behaviors and the lessons that we want them to learn, the better they're going to be able to hold on to it. And the best news is that even if you have a kid who has come from just a horrific abusive background, and they've bounced around the foster care system, it doesn't mean that we can't have an impact. We might have more of an uphill battle, but the brain is extremely malleable to change. It's extremely flexible. There's a lot of plasticity, and we can create those pathways for those kids, that connection between the limbic system and to the prefrontal cortex by just stopping and giving them the opportunity to learn, to talk about, even if they've they've done something and they're in trouble now, just this opportunity to stop and talk about it afterwards. You can still engage prefrontal cortex. What did you expect to happen? Okay, what happened? Why do you think that happened? What might have gone differently? What could you have done differently? All of this stuff is engaging that prefrontal cortex and allowing them to learn new ways. And that really is what the trauma-informed approach is about. It's about helping them learn we recognize the trauma, we recognize the impact of that trauma, and then we structure their environment in a way that will allow them to start where they are and to learn all of these things that maybe they didn't have a chance to learn in the past because they were so busy dealing with that traumatic event. All right, so it shapes behavior. It helps because we're catching them being good. We are recognizing their strengths. It helps them build their own capacity and their belief in themselves and their own abilities. It will strengthen attachment because they recognize that this is, and folks, consequences are hard for adults because we're the ones who have to enforce them. But if they see us persist, even when it's difficult for us, and do the right thing because it's in their best interest, then that will go a long way toward building that rapport and building that trust and the attachment. And when they trust us, when they are attached, when they don't want to disappoint, they tend to stick around. And that gives us more of an opportunity to have the impact on kids that we want to have because they stick around. They have the relationship. They hear what we have to say. They don't always like it, but they will listen. They do hear it. And it allows us more of a chance to have that impact. And it's, and they have that support that they need. It's all of those opportunities and structured events and activities and the relationship that was missing in the past. That allows them to kind of see that the world can be different and that they can do things differently. It does take time because we have to think about it. We have to think about, what do I want them to learn? Sometimes you sit down with the kid. What didn't work? What do we need to replace? What's going to work for you? And think about that and have that conversation. What can you do better or different? Not better. What can you do different that would make this situation better? What can we do? And sometimes that means we change as well. But it is future focused. And it's front loaded. It means that we're doing a lot of work. But we're doing work that will pay off for that young person in the long term. All right. So it's 12 o'clock. So, which was when this was supposed to end. If you guys, I'm welcome. I'm free to stay on. If you guys have questions, you can either unmute your phone, or you can type your question into the chat feature. Once again, if you want a certificate of attendance, I'm going to type in Jamisha's address, and you can do that in reference the training today. Let's go. Any questions? And I also will remind you guys that you're muted. So if you're trying to talk, you will probably have to unmute yourself.
I have to. Okay, I have to unmute. She said I need to unmute myself. You are muted. Unmuted. She's.
Yes, I can hear you.
Okay. Okay. Well, are you typing now? Because I do need that address because I need to have I need to have some papers so that I have attending this. And
I
it's
did.
Very interesting. And I thank you.
Yep.
It's very interesting. I enjoyed it.
Oh, and do you see the email address in the chat feature?
No, I do not. No, I don't. I just see questions and comments.
So it's J. So in the chat feature. Okay. So let me just go ahead and give it to you. It is J. Harris.
Wait a minute. Okay, wait a minute. Hold on. Let's put back in the chat feature. I think I saw it for a minute.
Yeah, you might have to scroll up.
Scroll up. Okay, let's see. Oh, well, here, I'll just J. Okay. No. Yep. Chat features. Okay. Well, that's not it. I'm looking for her address. There. Okay. Is this it? So now, okay. So now, are you all going to send anything to the certificate?
Yeah.
Will you all be sending us?
Yes. Yeah. If you email Jamisha, let her know that you would like a. So her name is Jamisha Harris. Let her know that you attended the webinar today. And ask for.
Wait a minute, where's her name? Don't take her name off. Is this right here? Yes, good. Okay. Now. Okay. Now. Hello. Yes.
Yes. Yep.
Okay. Now, so I need to email Jamaica Harris, right?
Yeah. Email Jamisha. Let her know. And she will email those back out to you. She will need, so if there was more than one person, she will need the names of all of the folks who were in attendance.
So okay. Well, you know what? I enjoyed this. I really did. And I was especially interested in the function of the brains. And what I wanted to ask you, if it starts in infancy and stuff, is there anything that we can do to stop it at infancy, to stop the trauma at infancy? And what is I guess the more it progresses, the worse it is.
I'm sorry, I missed the last part of it.
Okay, the brain. When you were talking about the brain. Now, is this at infancy? Is what you're talking about? Was that at infancy?
Actually,
age where?
No, we can intervene at any age.
Okay,
so. Yeah, I think that's the nice, beautiful part of the plasticity of the brain is that we can intervene at any age and make those changes. It takes longer the longer that you wait, but you can make those changes at any time.
Uh, okay, okay. See, I didn't know that it started. Now, does it start right at birth? The trauma. Does it start right at birth?
Well, I mean, I
Oh,
guess it
interesting.
depends on that situation. If you have a, I mean, if you have a newborn who's born, to, let's say, a mom who has either mental illnesses or substance abuse, and she's
Mm-hmm.
not immediately meeting the needs of the baby, then yeah, it can start that early. The baby's not getting fed, the baby's getting abused. It definitely can start that early.
Um, I wasn't aware that it could start that early. I thought it would have to be at least by the time they was like 2 or 3.
Well, I mean, if you think that the entire stress response is set really pretty much with, I mean, you set it within that first 4 months, then yes,
Mm-hmm.
it can be.
Oh,
Again, it can be moderated.
okay.
The
Well, you know
earlier,
what?
go ahead.
I really did. I really have enjoyed it and it was very informative. It really was. It was very
Oh,
informative. And I
thank
think
you.
I thank you so much. It was
Oh,
very
you're quite.
nice.
And who are you
Enjoyed
with?
it. I'm with Open Door Youth Shelter, New
Oh,
Albany,
okay.
Indiana.
Yeah, yeah. I know
Are,
open.
are, oh, do you? Okay. Okay. Yes, but I really did enjoy it and it was very informative.
Okay. Well, good to hear. I'm glad it was. Thank you.
Hmm. Hmm.
All right. Any other questions? All right. Well, thank you guys for attending. I appreciate the attendance. It was actually really well attended. And I'll get this hopefully uploaded to our YouTube site soon. And you can make this available to other folks as well. All right, guys, everyone have a great day. Thank you very much.
You too.
All
Bye.
right. Bye bye.